All right, everybody. Well, welcome and thanks for joining us on this very exciting solar eclipse Monday. Today we have Dr. Kelly Chin from the University of Texas Southwestern who will be joining us to be talking to us about pulmonary arterial hypertension or the medical management of pulmonary hypertension. One of the things that I just wanted to make a quick mention about is that in the chat, I put a link to the YouTube page, just because we have some new folks joining us. And For those that may not know about this, is if you're unable to attend on a given for a given presentation, these are always being hosted on the YouTube page, so you can come back and look at them later on. So, just feel free to go ahead and check that out if you'd like to in your spare time. So again, Dr. Chen, thanks so much for spending the time with us today, and please take it away.
All right, thanks. Happy to be here. So this talk is on the pulmonary hypertension medications. It focuses on the drugs themselves, a little bit on the trials, the side effects with the medication, and how they're used. So when I initially did this, it had some CME questions that with a little link to it. And I don't have the link working this time, but I'll throw them up there anyway, because sometimes it helps to focus just a couple of important things when prescribing these medications to be aware of. So
We don't actually have the PowerPoint up quite yet.
oh, okay, it's not showing?
Nope, we just see you right now.
Oh no. Well, okay, let's fix that. Okay, where did it go? That's my fault for trying to make a last minute adjustment that I didn't even end up doing. Back to share screen.
Yeah, it was there previously, so.
Yeah, I stopped it and I was gonna flip my screen because otherwise you're gonna see me looking off to the side as I see what slide I'm on. But
Yeah, looks
seeing it
perfect.
now.
Yep.
Okay, yeah, so here's the questions. So question one is, which of the following is not a paired medication and side effect with PH meds? So PDE5 inhibitors and headaches.
Okay, I'll be right back.
ERAs and lower extremity edema, riociguat and vision changes, and prostacyclins and gastrointestinal side effects. So you can think about that as we go through. And then the second one, this one's a really important one. Which of the following medications require monthly pregnancy testing for patients of childbearing potential? So it's the PDE5 inhibitors or the guanylyl cyclase activators, which is just riociguat right now, the ERAs, or the prostacyclins, or is it B and C? Okay, I have a few disclosures. I do a lot of clinical trial work, so I'm on steering committees and things like that. And then we'll get started. So this talk, as I said, goes through the pH pathways, what do the abnormalities look like in pulmonary hypertension, but is predominantly focused on the therapies. So which drugs are approved, what labs do we do, what clinical trials looked like. And then last, I'm sure many of you heard, or anybody who practices with pH docs, we had a med approved a couple of weeks ago called sotatercept. So I'll introduce that. This is the treatment algorithm as it looks like in the 2022 ESC/ERS guidelines. There aren't any more recent US guidelines, and they follow things pretty much as we do. And what it looks like is, and this just kind of helps to put in context as we go through the meds, the majority of patients will be started on a combination ERA PDE5 inhibitor upfront, meaning within a couple of weeks of each other. So either same day or start one, wait a couple of weeks, start the second one. Sicker patients should be started on those two drugs and an IV or subcutaneous prostacyclin, so triple upfront therapy. And that's going to be patients where the initial diagnosis is during a hospitalization with critical illness, but also some of your moderate to severe patients may benefit from this because it does seem like we get a greater benefit from earlier rather than later going to triple upfront therapy. So that's based on observational work. It was a mortality benefit with some nice propensity score adjusted analyses and such. Second line, it gets a little messier, but if you started with these two drugs at the moment, pre-sotatercept, the main third option is to add a prostacyclin if you don't get the desired effects with your initial two drugs. But the options are oral prostacyclins, inhaled prostacyclin, sub-Q or IV. So you have quite a few options there. There's a far right pathway that it says patients with cardiopulmonary comorbidities. that will likely be, it's clarified to some extent in the text. They don't mean anybody just because they've got hypertension, diabetes, obesity, that sort of thing. But most of our trials did limit the number of cardiovascular comorbidities you could have. And even trials that allowed patients with them generally found that those patients were more likely to have adverse effects with our medications and might get less benefit, although that's depends sort of your perspective. They definitely had less improvement in walk distance, which you might expect, and obese patients might not gain as much in walk distance. But time to clinical worsening and hospitalizations and things like that, they still benefited. So I think, well, it's clear these patients, if they truly do have group 1 PAH, and that needs to be clarified from the very beginning, that's one of the key things, they do still benefit from medications, but you may be a little more cautious with how they're introduced. So this is just saying maybe start with one drug rather than two. The pathologic changes that we see in PAH, so we often think about the PVR being high and it being a vasoconstrictive thing. I see this a lot post-op when somebody's had, say they had severe PH with mitral stenosis, which happens sometimes. You fix the mitral valve, now the left atrial pressure is normal, but the PVR is still high. And my ICU docs they've got a swan in and they're watching it and they're like, we can't get it to go down. And I'm like, yes, because the blood vessel looks like this right now. There's a ton of remodeling that happens in all forms of PH, and it's highly variable. So that's why you sometimes see a patient in the cath lab who is very vasoreactive. You give them nitric oxide and they vasodilate and their PVR comes down. But you see a whole bunch of patients where it doesn't. And it's both the endothelial layer and the smooth muscle layer. It can vary from patient to patient, with some patients looking more like this. Obviously, we don't go do biopsies, so we don't really know, but based on autopsy and other series, you can have mainly smooth muscle proliferation with just a little endothelial proliferation, or you can have a lot of endothelial proliferation, or you can have plexiform lesions where some vessels are just absolutely destroyed and not really functional. And you can imagine you're probably not coming back from that. So if you're developing this and it's gradually worsening over time, no matter how much you can open up the other vessels, if you're not working on this as well, that things aren't going to go well. Pre-sotatercept, these are our 3 pathways that we have. So the one that everybody I think is probably most familiar with is going to be this nitric oxide pathway, because we've got Viagra and Cialis down here. So sildenafil and tadalafil are PDE5 inhibitors. You have nitric oxide, which stimulates cyclic GMP production. And then if you have a PDE5 inhibitor on board, this hangs around longer, so you get vasodilation, and over the long run, it's antiproliferative. You can also activate this directly by giving your patient nitric oxide or by giving them riociguat, which is our soluble guanylyl cyclase stimulator. And the potential advantage of that is in areas of the lungs where you don't have a lot of nitric oxide being made, this will still stimulate cyclic GMP production. So it has the potential of being stronger than PDE5 inhibitors. We don't exactly have head-to-head studies because it wasn't blinded, but they did do a study where they took people on a PDE5 inhibitor and randomized them to stay on it versus go on riociguat, and it looks like they probably got some improvements with riociguat, but there's some downsides to that as well. It causes more hypotension, so this lack of systemic the systemic circulation doesn't have a ton of this pathway going on naturally, but it does have the receptor. You, in theory, could get some hypotension from sildenafil and tadalafil, but clinically you almost never do outside of situations where your patient's already tending to be hypotensive, like the ICU. So in outpatient medicine, we really don't worry about it very much in patients. This drug, though, causes a lot of hypertension, and there's a whole pathway to prescribing it where you check the blood pressure, start the medicine, recheck the blood pressure 2 weeks later, increase the medication dosing, and so on. Then our other 2 pathways, we have the endothelin antagonist. Over here, endothelin is a substance that your body makes that causes vasoconstriction. Sorry about that. If you block it, you get less vasoconstriction, and over the long run, you get it's antiproliferative. And then you have the prostacyclins. So you've got the 3 medications over 3 different routes of delivery over here for medications. You've got IV and sub-Q, 4 routes, IV and sub-Q, inhaled and oral, that are all working through this prostacyclin receptor and increasing cyclic AMP. You can use all of the pathways together. The only thing that you don't want to do together is these 2 medications. When taken systemically, that causes too much hypertension. And the trial that looked at that, they had some serious hypertension and it was halted. There are still some studies going on with an inhaled soluble guanylyl cyclase activator to see whether you could use it in combination with a PDE5 inhibitor. We have some preliminary results from that, and it does appear to be a safe thing to do. So now they're looking for efficacy to see whether that might add some benefit in pH. This talk is all about group 1, so I don't get into the other groups very much, but it's worth just kind of a general overview. So all of these medicines, this is what we're talking about today, are approved for group 1 pH. We've got nothing approved for group 2. You do see some off-label use, mainly of the PDE5 inhibitors, mainly sildenafil. From a safety standpoint, we used to say at least it's not harmful. We had some reasonable sized studies in HFpEF, for example, where it didn't seem to hurt. These patients didn't have pH, didn't seem to help either in HFpEF in general. But we're now starting to have some studies where it looks a bit more negative. There's a post-valve study late. Everybody had high wedges. These were people who didn't have either a good result or they also had some HFpEF. But in any case, they had more hospitalizations with sildenafil. And there's a HFpEF study that's I've just seen in preliminary view, but there was also a trend towards harm there. So we're, I think, increasingly cautious about using anything in group 2 pH other than treat the underlying condition. For group 3, it's a little more mixed. Inhaled treprostinil is now approved, and sildenafil in a subset of patients and some really tiny studies has seemed to show some benefit. So we do still see patients on definitely this and sometimes sildenafil. For CTEPH, riociguat is approved, and then for group 5, we don't have anything approved, but we do have a randomized control study of sarcoid where there were trends towards improvement, so we'll use it sometimes there. So back to group 1 though. Before I get into some details about the medications, to prescribe both the ERAs and riociguat, there's this thing called a REMS program. This is a program you have to sign up for. It's relatively easy. You just have to fill out some paperwork where you promise that you will check pregnancy tests and patients who need to have that done. And then for bosentan, it also has some warnings about liver function monitoring. We don't use bosentan much because of that. The other drugs in its class don't require it. It also has more drug interactions. There's a number of reasons to use the other ones. But you sign up and you basically agree to do this. And then when you prescribe the medication, it doesn't go through a normal pharmacy. It goes through a specialty pharmacy. The medication is shipped directly to the patient. The patient also has to sign up and say that they agree to this monitoring. And then every month before it's sent, for my patients who need a pregnancy test, that's one of my nurses' big jobs, is making sure that they've got the pregnancy test checked and send the medication off. And this is due to some craniofacial abnormalities with the ERAs and some other serious fetal abnormalities with riociguat that's seen in animal studies of the drugs. The prostacyclins also come from specialty pharmacies. They don't have any special monitoring, but there's a lot of teaching and the dose range is quite large for these. And so the specialty pharmacies actually help with this. And they also do the teaching for the IV and the sub-Q prostacyclins. There is no home nurse to administer these. The patient or the family has to entirely do it themselves. But they have 3 or 4 days of teaching with the specialty pharmacies, usually before initiation when possible, sometimes after if they're really sick. And they have to have that down before they can leave the hospital. Busy slide here, but this is all of the either pivotal trials or other just really important trials that altered how we prescribe these medications. And I wanted to provide it as just kind of a general overview of the 3 main types of clinical trials that you see in pulmonary hypertension. These first 2 are more or less the same. These are trials that had 6-minute walk test as their primary endpoint. The FDA will accept that as an endpoint because it's a rare disease, so it doesn't require quite as rigorous a level of evidence, but requires some patient-centric benefit, so it can't be just cath. And the first era, everybody is basically on nothing. So this is background therapy across here. So these patients are on nothing, or about 16% were on background therapy. So most of them were on nothing. Primary endpoint is 6-minute walk. The little diamond shows the primary endpoint, except this study, which had co-primary endpoints. And then this is the meters improvement placebo corrected. So these are really sick patients. The placebo group's usually going down 5 or 10 meters, even in the 12-ish week study that's happening. And then the group that's getting the active drug typically improved versus their own baseline by around 30 meters or so. So significant improvement there. They're feeling better. Their functional class is usually improving. Studies look really positive. But that's not really ethical to do in the current era with all of the approved medications. So the next set of studies is more or less the same thing, except patients are on background therapy. So they're allowed to continue whatever they were on, and then they're randomized to the new study drug versus placebo. In some studies, just a couple of them, it was only about half. This was sort of the transition phase, depending on what country the study was done in and that sort of thing. But 6-minute walk is still the primary endpoint. And the meters of improvement starts to be not quite as large. And this is partially because the placebo group is on a background therapy, so they're often more stable, and you'll see their walk test just be kind of flat. Or sometimes even you get a little placebo effect and it's bumping up 5 meters or so. You can see 2 studies that don't quite meet their primary endpoint. We had 10 meters and 11 meters of improvement, and the p-values were between 0.05 and 0.1. So they got close, so the company just kept trying. They did one more study with this drug in this third category, and these are studies where instead of using 6-minute walk, although they still measured it, instead of using 6-minute walk, they use time to clinical worsening as a composite, which is usually hospitalization, reduction in walk test and functional class, or death, sometimes with one more piece to it. And they saw often 40 to 50% reduction, so pretty big reductions. For oral treprostinil, it was only a 26% reduction, but still met their endpoint and ended up being approved by the FDA with that. So the other studies are mostly still new drug, allowed background therapy. One exception, though, which was a really important trial for us, which showed the benefits of upfront combination therapy and really changed how practice went. And that was called Ambition, which looked at ambrisentan and tadalafil, either both or one by itself. So it was 2 drugs versus 1, and even 2 drugs versus 1, they still got a 50% reduction in clinical worsening, showing how powerful it is from the beginning to really get patients on at least 2 medications. One was quite inferior. A sub-study looked at cath. They also saw improvement in walk, although only 25 meters. So overall, very highly positive study. Okay, individual medications. I'm not going to talk about the studies again, but just briefly some additional info. So the PDE5 inhibitors mostly used upfront combination, either with macitentan or ambrisentan, and the most commonly used one is tadalafil because it's once daily, although sildenafil is a little cheaper. Both have gotten fairly cheap and aren't too difficult to utilize. The main side effects for the PDE5 inhibitors are headache, and because of that, when we use tadalafil, which the full dose of it is 40 milligrams, we usually start at 20, do it for about a week, and then up titrate to 40. The 20 milligram dose showed some improvement in clinical trials, but 40 was quite a bit better, so we try to get everybody up to 40 if we can. Other side effects are mostly annoying. Some people get more frequent nosebleeds. You see some increase in reflux. Some people get flushing. And then very rarely, I've actually never seen it in a PH patient, prolonged erection or vision changes, but it's reported with the use of these medications. Can't use them with nitrates, can't use them with riociguat, but no specific monitoring. So fairly straightforward there. Next up, the ERAs, the 2 most commonly used are ambrisentan and macitentan because they don't have required liver monitoring and because they're once daily, so they're nice and convenient from that standpoint. The main side effect to watch for them is edema. And if you have an older patient or a patient with pre-existing edema, or a patient who's just sicker, you definitely want to see these patients fairly soon after starting the medication, because the edema, if it's going to happen, it's usually in the early weeks. It's more likely in patients who don't have group 1 pH. If you try to use these in heart failure, there's big studies showing you had more hospitalizations, more fluid overload, more fluid retention. It definitely causes it there, but it can happen in PAH as well. And we usually treat through it. So we add diuretics, we adjust diuretics, and so on. A small subset get anemia most of the time. I would say a small set get anemia that's severe enough to think about stopping the medication. We do see a little more often small drops in hemoglobin. We usually just keep an eye on that. It may vary from one drug to the other. And so both for edema and for anemia, we may switch within the class. So from macitentan to ambrisentan and vice versa. But there's no head-to-head trial, so it's really hard. You're comparing across different studies when you're trying to figure that out. Our typical monitoring, so monthly pregnancy, as we've talked about, and then for the first year, quarterly labs, which would usually be a CMP because we're watching kidneys as well, and a CBC to monitor for the anemia. It's not absolutely required, and you can adjust this as you see fit. And we usually start spacing it out a little bit, not the pregnancy, but the everything else, maybe to every 6 months, unless you're needing to do it for diuretic reasons or they've developed anemia or things like that. And then obviously talking about birth control. Riociguat. So Riociguat is also a pregnancy ex-med. You've got to do the monthly pregnancy monitoring. From a side effect standpoint, the biggest thing with it is hypotension. So there's a whole, how do you start it? You measure the blood pressure. SBP needs to be above 90. If it's below that, unless there's meds that you can get rid of, like they're already on some antihypertensives or something like that, not the best drug for them. So we would probably stick with a PDE5 inhibitor. But if the blood pressure is above 90, you start at the 0.5 milligrams 3 times a day dose, and then watch for a couple of weeks, recheck the blood pressure. You can do this through a home health nurse if you don't feel like, if the patient's at a distance and you don't want to bring it back into clinic, and you do it every 2 weeks until you get up to the desired dose or they develop hypotension. And the full dose is 2.5 milligrams 3 times a day. There's some constitutional type symptoms. They can get headaches, the GERD, some nausea, diarrhea. Most of the time you can treat through this though. All right, then our last class of medicines, except for the new sotatercept, which we'll talk about at the end, is IV and sub-Q and oral treprostinil and inhaled treprostinil and Selexipag. These are the 3 routes other than oral. So for IV, EPO and treprostinil, this is a CAD legacy pump going through a line. It goes continuously. The half-life of epoprostenol is 5 to 10 minutes. The half-life of treprostinil is 2 to 4 hours. If the medications are suddenly discontinued, particularly epoprostenol, which goes away so fast, you can actually get rebounds in animal models. If you start the drug, pulmonary pressures go down. If you stop it suddenly, they rebound above what they even started at. So obviously people can get really sick with that. So you don't want them losing their IV access or leaving their pump off or sudden discontinuations and so on. The other side of this is if somebody does stop their medication on accident or, some event happens and they're off of it for several hours, when you go to restart it, they may get an exaggerated response to it where they get really hypotensive. So we will often drop the dose to by a third, sometimes as much as half if they were off of it for a long period of time, and then slowly up titrate in the hospital rather than restart at the full dose where they may get hypotensive. For sub-Q administration, it's a much smaller pump, and then they're switching from this older one to this newer one. Not a big advantage with one versus the other. The main disadvantage to subcutaneous administration, though, is it's painful. So we don't actually have a lot of patients on it. 90-something% of patients have pain. You can often treat through it, but many patients over the long run find it not worth it. But you do get rid of the risk of line infections and thrombosis and all those sorts of things. The inhaled medications, this is an older medication called iloprost, which we're no longer using. This is the main way treprostinil was given up until 2 years ago. This is a newer version where it comes as a little pill. You put it into the device, you squeeze it like Spiriva, and you inhale it. And it's 4 times a day. The nebulizer is 4 times a day as well. The way it gets paid for is a little different if you're on Medicare for this versus this. This may be covered better, and so we like cost-wise for the patient. So we still have a lot of patients that are on this. And then some patients notice more cough or other side effects with one versus the other. So we still have quite a few using both. We're using this mostly in interstitial lung disease patients, but it has fewer prostacyclin type side effects. So if a patient has a lot of side effects with oral, we might switch to inhaled. Neither are as strong as the IV and sub-Q, so those are definitely our first choice for our sickest patients, though. Management really requires a whole team, things you don't even think about, like how do I get an MRI with this pump? Well, we use extension tube. The pump goes outside the room. It's not MRI compatible. There's just a whole lot of hospital things that are involved. And so if a patient gets admitted to an outside hospital, we try pretty hard to get them transferred in, where we do have the pharmacy and nursing and all the support staff to do things like not accidentally bolus this medication by using their line for something else, which can cause hypertension and so on. The prostanoid side effects are mostly annoying ones, other than hypotension, which is mainly with overdose or if you get to really high doses. But the annoying side effects are really common: flushing, headache, diarrhea, jaw pain, leg pain, total body pain. They can be really, really annoying. So we do a lot of teaching expectations. We'll give patients nausea medicines, diarrhea medicines. Sometimes even I'll go with hydrocodone for while I'm up titrating, although we try not to, try to just stick with Tylenol if we can. And also manage the dose based on side effects. So you limit the dose to the dose increase rate based on that. And this is just a little info on dosing. It's probably getting into the weeds a bit too much, but it's what doses were used initially at 12 to 16 weeks and at 12 to 18 months across a bunch of different studies, just to give you a general ballpark if you are starting it. There's studies out there that you can look up to see what typical doses look like. There's also such a thing as overdose. This comes from over 20 years ago, where they were using very high doses because they thought they needed it. And what they found is they were causing high output heart failure. It will lower your systemic vascular resistance so much that your cardiac index goes up and up and up. And so we do recommend repeating hemodynamics in patients to make sure that this isn't happening before you go to really high doses. And for us, that's at about 20 nanograms for IV epoprostenol. We would repeat hemodynamics and then either sit tight if we've gotten the effect we need, or can continue up titrating. I'm going to skip over just a little bit because I want to get to sotatercept. I added it without taking away, I think. Sotatercept. Okay, so our new medicine that was approved just a couple weeks ago is an activin scavenger, basically, and it works on the same pathway as the BMPR2 pathway. If you're familiar with heritable PAH, most of it's caused by a loss in one gene of the BMPR2 receptor. Even the non-heritable forms of group 1 PAH tend to have reduced signaling in the BMPR2 pathway, even though they don't have a genetic mutation. And so there was a lot of interest in developing medications that would increase signaling over here. The problem is you're trying to increase signaling, but you don't have the receptor. You don't have it in the normal quantities. And so an alternative is to look at the counter-regulatory pathways, which are these activins. And with increased activin signaling, you get an increase in these counter-regulatory proteins, and you get less effective signaling of this. So what they did was they came up with an antibody, binds up activin, so that you get less of this, and in effect, your balance is adjusted so that you get more of this pathway over to the left, and overall alters the signaling through these TGF family of signaling pathways. There's a bunch of animal data I'm not going to go over, but some really fancy studies showing how much better it looked. They even had an active control with sildenafil as far as the remodeling aspects of pulmonary hypertension. And there's a lot of excitement about this medicine because it doesn't appear to, it's not a vasodilator. It works only on the growth and remodeling aspect of pH. And we really, really need that because right now we're using 3 meds that are mixed. They have strong vasodilator effects. So you end up, when you're on all 3, getting quite a bit of systemic spillover vasodilation there. and not enough effect on the growth and remodeling, which continues. And they really hit a home run with their study so far. So there's been a ton of excitement. In their first study was a phase 2, 106 patients. Then a more recent study was phase 3, 323 patients, and they showed an improvement in walk distance, PVR, NT-proBNP, functional class, time to clinical worsening, and quality of life. And that was despite about 2/3 of their patients, almost 2/3 of their patients being on triple therapy with an ERA, usually either PD-5 or the soluble guanylyl cyclase activator and a prostacyclin. So super excited about it. FDA approved now, will be available probably in a few weeks, although it may take a while to get onto insurance. So things to know about it. It's a sub-Q injection every 3 weeks. It was generally well tolerated, and people were so excited about it that even if they were having side effects, they tried to stay in the study. So the dropout rates were very low in the phase 3 study, I think, because people had seen the very positive phase 2 studies. It lowers PVR. It actually increases SVR slightly, which is interesting, and increases MAP very slightly, but that's okay. Our patients are running really low, so we're not really very worried. Actually, that's kind of maybe a good thing for our sickest patients. It didn't increase cardiac index, but improved RV function. So that's more than I have time to get into here, but one big difference in it versus prostacyclins and may influence where we use it. And then weird side effects. It has 2 vascular side effects. It causes both bleeding and new telangiectasias. Not a ton of bleeding, but enough to worry us because our patients are prone to it. So it causes nosebleed, but there are also a couple of GI, CNS, or hemoptysis events in both the main trial and then a few more in the extension phase. So definitely that's something to monitor and think about if we do prescribe it to patients at high risk of bleeding. And then a small number of patients got new telangiectasias, for which in the trial, the dose was either lowered or stopped depending on the severity. Then the last weird thing, it increases hemoglobin. So this is also checked before each dose, and if it becomes elevated, the med's stopped. Okay, so that's it. So we're going to be moving from maximal therapy being 3 drugs to potentially being 4 drugs. Initial therapy right now is 2 for most patients, but a subset who's really sick start on 3. And then with inadequate response, the new guidelines will say potentially up to 4 drug therapy because a majority of patients were on 3 in the sotatercept trial. A lot of side effects. I'll skip through that. And then just a reminder about the pregnancy monitoring with the ERAs and with riociguat, which is why you have to sign up for special programs to prescribe them. And then the answer to these questions, riociguat doesn't cause vision changes, and the monitoring is both B and C. Yeah, and I will stop there. If you guys have questions, happy to stay on for a few minutes and answer questions.
Yeah, well, that's fantastic. Thank you so much. So any questions out there from the group at this point? You can either raise your hand or just unmute yourself, and feel free to ask if you have a question. Sure. So is it so, as a advanced heart failure cardiologist, and not as a pulmonary hypertension specialist per se, I think a lot of the times where where we may be seeing patients are, at least, I mean, I'm obviously in an academic center, and some fellows will not end up working in academic centers. They will be more in community-based settings. I guess at what do you feel it's pretty pretty safe to say that, as somebody with advanced heart failure training, probably is okay getting these patients started on the initial oral therapies, the macitentan, the tadalafil, but once you're kind of failing those types of therapies, they require referral to, a pulmonary hypertension center, or would you recommend kind of going straight to a pulmonary hypertension center and then even just as a consultation before you would start any of those first-line oral therapies?
We're always happy to see people right up front, and I have patients coming from all over the place, as I'm sure you do. But at the same time, some of your patients aren't going to do that. They're just going to be like, yeah, I'm sorry, that's 2 hours away. I can't possibly drive down there.
Absolutely.
I think if you have a patient who looks like the patients who were in clinical trials, it's fairly straightforward to follow the treatment algorithm. So you pull it up, you get 2 drugs up front, you start them, reassess them pretty early, 3 to 6 months. And I even tell people up front that our goal is to get your heart function looking normal. And if it's pretty abnormal at baseline, that very well may not happen with 2 drugs. If it is pretty normal, it'll probably stay there because you lower PVR 40 to 50%, that's great. But if it's really abnormal at baseline, it's probably not going to get there. So I'm going to already be starting to talk about prostacyclins. If I were at a center that didn't give them, I would start talking about that. Okay, we'll do this here, but we're going to reassess things at 3 to 6 months, either with echo or cath or both. And then if it's not where we need you to be, even if you're feeling better, you really need to go because the 5 and 10-year outcomes aren't going to be as good if we don't get your heart function close to normal pretty early on. The part of that that's messier, though, is that most patients in clinical practice don't look like clinical trial candidates, right? They're a little older. They've got a few more heart failure risk factors, even if they don't overtly have HFpEF or whatever. And those patients are really hard. Am I even treating the right condition, or am I going down the wrong pathway here, and so on? So, I think unless you do a lot of it, it's really hard to manage that, and you want to try and get them into a specialty center. But I do have colleagues a lot of our fellows who trained with us, and they're 3 or 4 hours away, and they do quite a bit of this, and they've got me in their cell phones, and I'm happy to answer questions. So I think if you're going to do it, that's what you want to have, that relationship where they start it, but they're calling me with like, oh, I have this weird thing. What would you do here?
It makes a lot of sense. And I may have missed it, but do you think there's going to be any role for investigating sotatercept as a first-line drug or just as an add-on after these other oral therapies that you had mentioned?
I mean, it works so well. So people are very excited about it. But these side effects, you got to take some pause about that. Like, what are we doing to people's vasculature? Do you really want to start a 20-year-old on this who may then take it for the next however, long time that we're talking about? So I think it will probably stick to be as early reassessment, 3 to 6 months, but not upfront. And if you get a great response with drugs that have been out for 10, 20 years, stick with them. But if you don't, if you're looking at survival estimates of less than a few years, then I don't really care what it might do 10 or 20 years from now. Let's do it. But if they're doing okay, then I'd like to know more about this. And that might change as we learn more about the side effects. But right now, it's just so different from anything we have out there right now.
Yeah, I remember there's a lot of excitement. I think it was back at the HFSA meeting in the fall. When some of the or it may have been ACC last year. I don't recall exactly when some of the trial data initially was being presented. I just remember.
Yeah, I think it was ACC last year
ACC
because I
last
had a
year.
small prezo there, and everybody was
Okay.
all sotatercept.
Yeah. No, it was a lot of excitement, something new in the space. That was fantastic.
Yeah.
So, all right. Well, Dr. Chin, thanks so much for your time. Thanks everybody else for joining. Everybody enjoy the eclipse later this afternoon, and take care. We'll talk to you later.
Very good. Bye-bye.
Bye.